Hello everybody, and thank you for joining me in this new video from ARIA EpiTalk series regarding hemodynamic support during catheter ablation of ventricular tachycardia. I hope you will enjoy this presentation and video and join me here in my future short videos. If you are new to my channel, please do not forget to subscribe. In this short video, first we will see an introduction and then the review of the published studies, a short review, and after that, 4 examples of hemodynamic support during VT ablation and some practical points at the end for hemodynamic support during catheter ablation of ventricular tachycardia. Hemodynamic support is usually used during catheter ablation of scar-related VT. In 60% of the patients, we usually have scar-related VT in combination with infarction or ischemic heart disease. In 30 to 40%, and this is increasing, we have scar-related VT in patients with non-ischemic cardiomyopathy. The VT in this constellation is more complex and usually the procedure is longer, and we need some endo and epicardial approach to finally ablate the clinical and all-inducible VTs and modify the substrate. So the procedure is usually longer and more complex, and that's the reason why we usually use hemodynamic support during catheter ablation of VT in patients with non-ischemic cardiomyopathy. When we have hemodynamic instability during VT ablation, these hemodynamic instability have some harmful cumulative effect on end organ perfusion and function. In addition to lactic acidosis, this may lead to activation of systemic inflammatory cytokines, and all these can cause myocardial contractility impairment of myocardial contractility, which creates acute heart failure during or shortly after catheter ablation, which can increase the in-hospital mortality and also hospital stay in these patients. How can we predict hemodynamic instability? One of the ways to predict hemodynamic instability during VT ablation is Penn-St score. With this score, we can classify the patients in low risk, intermediate risk, and high risk. And the higher the risk, the higher would be the risk of acute hemodynamic deterioration during catheter ablation. For example, as you can see here, if the score is more than 17, the possibility of acute hemodynamic deterioration and heart failure during catheter ablation reaches to 24% of the patients. One important thing, this score not only predicts acute heart failure and acute outcome during VT ablation, but as you can see here in one of our studies, it also predicts long-term mortality and outcome after catheter ablation of ventricular tachycardia. We have different kind of possibilities for hemodynamic support. I usually use the Impella CP as the standard for hemodynamic support during VT ablation. We have some other options, some other devices like tandem heart, and also in rare cases and rare patients, as we will see in the case studies, we have to use ECMO for complete hemodynamic support. The alternative would be Impella 5.0. This is one of the first studies published on 68 consecutive patients. This is a retrospective, non-randomized study. A 68 catheter ablation procedure performed in 63 patients, 34 procedures with and 34 procedures without percutaneous left ventricular assist systems. And as you can see here, using of percutaneous left ventricular assist systems and devices was associated with shorter ablation time and reduced hospital stay. While this support did not affect the VT recurrence, it also was associated with a lower composite endpoint of 30 days rehospitalization, redo VT ablation, recurrent ICD therapies, and 3 months mortality. In another study, very important one, data from 230 patients with percutaneous ventricular assist devices were presented, and these were the patients who were captured by the Medicare database, and catheter ablation of VT associated with mechanical support was associated with reduced in-hospital cardiogenic shock, renal failure, length of stay, hospital readmission, and also mortality during follow-up, but hemodynamic support make no difference with respect to redo VT ablation at 1 year. This is one of the interesting studies which showed a reduction of the long-term mortality in patients who received hemodynamic support during catheter ablation. Another important study also assessed use of percutaneous left ventricular assist device and showed that most appropriate use would be in patients with non-ischemic cardiomyopathy, electrical storm, who has advanced heart failure, and severe LV dysfunction. As we said, this is exactly like Payne's D score. We have to select the patients who are at higher risk of hemodynamic deterioration during catheter ablation, so we can plan using hemodynamic support during the procedure. This is a very important study. The authors included 75 patients who undergoing catheter ablation of scar-related VT, in whom a prophylactic percutaneous left ventricular assist device was implanted, and then they compared the outcome in these patients with another 75 patients who did not undergo prophylactic percutaneous left ventricular assist device placement, and they're using the propensity matching for selecting the control group using the Payne's D score. And they showed that prophylactic use of hemodynamic support in high-risk patients is associated with reduction risk of acute heart failure as showed by the other studies, but also reduces the risk of death and transplantation during follow-up without affecting the VT-free survival, as the other studies also showed. This is very important study which showed that prophylactic use, not rescue use of hemodynamic support, improves the long-term outcome in these patients. So it's very important to filter high-risk patients and to use the hemodynamic support in these patients in a prophylactic manner. One of the most important thing is, except from percutaneous left ventricular assist devices, we can also use ECMO, extracorporeal membrane oxygenation, for hemodynamic support. And this study also from Paolo Della Bella group showed clear positive effects of hemodynamic support in this patient. But regardless of which hemodynamic system we use to support the patient during catheter ablation, we always have to keep in mind that sometimes it's very difficult to wean the patients from the hemodynamic support. So every time when we use the hemodynamic support in a prophylactic way, we have to think about what is the next step if we are not able to wean the patient from hemodynamic support, and what is the next step, going for implanting a left ventricular assist device or going for high urgency cardiac transplantation. And we have to discuss these points with the patients if hemodynamic support cannot be weaned after catheter ablation. Hemodynamic support has some complications, especially vascular access complication, but there are also some rare complications, as you can see here. In different studies, during between 6 to 72% of the 62% of the patients have some degree of hemolysis, and this may lead in very rare cases to acute kidney injury and acute renal failure, as you can see here. Now we go to our case studies. Our first patient is a 48-year-old man with non-ischemic cardiomyopathy, low ejection fraction, LV ejection fraction 30%, electrical storm, and VT cycle length 460 milliseconds. Two previous ablations were unsuccessful. So for this patient, we just used norepinephrine perfusion, and with the doses of 3 to 15 microgram per minute, and that was enough to make an unstable VT stable. And as you can see here, we had some targeted mapping and very short map during VT, targeted finding the earliest point, and then successful ablation of the scar-related VT. So sometimes just some norepinephrine perfusion can help us to make an unstable VT stable at least for several seconds, up to 1 minute. And in this case, especially using multi-electrode mapping, we can make a fast map, find the location of the VT, and then go for the ablation. The second patient was a 60-year-old man after bypass surgery who experienced monomorphic PVCs, short-coupled PVCs, and after that, these PVCs induced ventricular fibrillation. So the patient was on ECMO, and we did catheter ablation. Here you see the 12-lead ECG of this PVC, which is clearly a left ventricular septal, inferoseptal PVC with the QRS duration is small, as this is the case in many patients with Purkinje induced Purkinje PVCs, which induces ventricular fibrillation. Here you see the application of multi-electrode mapping, which accelerates the procedure and shortens the procedure time. We did a detailed activation mapping and pace mapping, and after that, first we targeted the clinical PVC, and after that a substrate modification and ablation of the late potentials. The patients were electrophysiologically stable after the procedure, no arrhythmia, weaned from ECMO, extubated and discharged with, of course, an ICD implanted. The next patient is a 75-year-old man with coronary artery disease, 3-vessel disease, bypass surgery, mitral clip, and ejection fraction of 15 to 20%. He was admitted with electrical storm. VT cycle length, clinical VT cycle length was around 430 milliseconds. Previous attempt to do the VT ablation without hemodynamic support leads to electromechanical dissociation and short time resuscitation. So we planned the procedure with hemodynamic support. As you can see here, we implanted first an Impella CP percutaneous assist device. This is the first position, but as you know, we have a marker in the middle of the hemodynamic system, and these markers should be placed at the level of aortic valve. So this hemodynamic support helped us to do a detailed activation mapping and perform the catheter ablation. Here you can see the catheter ablation from left side of the septum with the retrograde approach, and this is the map at that time with the point-by-point approach. On the right side, the substrate map. On the left side, we have our activation map. And despite catheter ablation from left side, we were able to terminate the VT, but the VT remained inducible. And finally, we ablated from the right side, on the earliest point on the right side of the septum. And finally, this ablation rendered the VT non-inducible. Last but not least, the last case, 76-year-old female patient who experienced recurrent PVC-induced polymorphic VT and VF on the third post-bypass surgery. Coronary angiography showed that the grafts are patent and open and no new finding or stenosis. Ejection fraction at the time of catheter ablation was below 15% after frequent shocks despite antiarrhythmic therapy. ECMO was implanted, and here you can see the ECG during catheter ablation, which always we had some short coupled PVCs, and each time this PVCs induced polymorphic VT-VF. Here is the map which showed the scar on septum. The yellow circle shows the location of the clinical PVC. After ablation of the clinical PVC, the rhythm was stable, but despite that, we did a substrate modification also on the septum. This patient also was discharged several weeks later in a stable condition for rehabilitation and finally survived this procedure. Hemodynamic support is something that we have to plan very carefully, and therefore that's the reason why a prophylactic use of hemodynamic support is much better. So optimizing patient outcome during hemodynamic support in VT ablation, first step is pre-procedural preparation. We have to know the coronary status of the patient, 12-lead ECG of the VT, cycle length, rate, morphology, because the shorter we use the hemodynamic support, the shorter is the ablation procedure, the better would be the outcome. If it's possible, 12-lead ECG from one previous failed VT ablation. Substrate characterization, localization, using MRI or reviewing the previous 3D maps. Ventricular function, valvular function, LV thrombus. We should know about all this before going for hemodynamic support. Vascular access assessment, antiarrhythmic drug therapy, and also anesthesia review before the ablation procedure. The team is very important. It's not just an EP, but the team for hemodynamic support have different members, from interventional cardiologists, cardiothoracic surgeon, and anesthesia, perfusionists, and vascular surgeons, lab and theater nurses experienced in such kind of procedures, and of course mapping and EP technicians. And very important point, especially in these days, which is limited number of available beds on intensive care units. Before doing such procedure, we have to always be sure that we have a bed for the patient on intensive care unit. The equipments, we have to check all the equipments, and especially the catheters plus spares. Everything should be available. ECMO pump and long lines if necessary. We have to think about it. The perfusionist should know the lab and how long should be the connections to all the systems to function properly. Cerebral oximetry monitoring and precardiocentesis equipment should be available and should be ready. And percutaneous cut down equipment, vascular closure systems, everything should be available. In the procedure, we have secure continuous power. It seems rudimentary, but it's very important. Securing the continuous power supply to all the systems and all our devices, including perfusion pumps. If we are planning to do for epicardial access, it's better usually do the epicardial access and then go for mechanical support and ECMO. Invasive arterial pressure monitoring is very important, continuous pulse oximetry, and in some patients we have to consider central venous or pulmonary artery catheter for the monitoring. Also urine output, hourly fluid balance assessment, blood sugar, lactate, and anticoagulation, especially with the ACT over 250 seconds, should be considered during hemodynamic support. At the end, I hope you enjoyed this video, and I would like to invite you joining me in my future video presentations. Once again, thank you for your attention.